and talk on a very uncommon topic in usually diabetes conferences. So to be honest, we don't do prolactin levels in our diabetes patients. It's usually the obstetrics and gynecology, they do these tests. So my talk will cover to review the causes of hyperprolactinemia, describe the evaluation of a patient with hyperprolactinemia, summarize the treatment of the same, and also how do we deal with professional team members. So prolactin hormone is exclusively synthesized and secreted by the lactotrophs of the anti-pituitary gland. The secretion rate of prolactin is around 200 to 536 mcg per day per meter square, and half-life is around 25 to 50 minutes, and 75% of it is metabolized in the liver and 25% in the kidneys. And the basal level of prolactin in women averages around 13 nanograms per mils, and in men it is around 5 nanograms. The upper limit of the serum prolactin level is mostly in our laboratories 15 to 20. This is usually in men and premenopausal women. In premenopausal it's usually up to 30. So in men and premenopausal it is postmenopausal 15 to 20. So when the amount exceeds, it's known as hyperprolactinemia. So the hypothalamic control of prolactin secretion is mostly inhibitory by the prolactin inhibitory factor, and dopamine is the main inhibitor that acts via the type 2 dopamine receptor located on the lactotrophs. And the TRH is a potent prolactin releasing factor. There is an elevated response to both TSH and prolactin in primary hypothyroidism. So other prolactin releasing factors are the vasoactive intestinal peptide, endothelial growth factor, and dopamine antagonists. So hyperprolactinemia occurs in less than 1% of the general population, occurs 5 to 15% of patients who present with secondary amenorrhea, and 25% who present with galactorrhea, and the prevalence was found to be 17% among women with PCOS. The most common type is a prolactin secreting tumor, accounting to up to 40% of all the clinically recognized pituitary adenomas. So it is estimated to be around 30 per 100,000 women and 10 in 100,000 men, and the peak prevalence in women is between the age of 25 to 34. And the clinical manifestations in women are more obvious and present earlier than in men. So the common causes of hyperprolactinemia is physiological, pathological, or drug-induced. Patients with hyperprolactinemia may remain asymptomatic or can present with signs and symptoms of hypogonadism and galactorrhea. So some of the physiological causes are pregnancy, nipple stimulation, lactation, exercise, stress, seizures, sleep, neonatal period, sexual intercourse. However, physiological hyperprolactinemia is transient and adaptive. So the other pathological causes are prolactinoma, acromegaly, Cushing's disease, macroadenoma, plurihormonal adenoma, lymphocystic hypophysitis, paracellular mass, and macroprolactinemia. So hypothalamic disease due to stalk damage, tumors like the craniopharyngioma, suprasellar pituitary mass extension, meningioma, dysgerminoma, and granulomas like sarcoidosis, tuberculosis, infiltrative disease, Rathke's cyst, pituitary stalk transection, and cranial irradiation. So the large non-functioning pituitary lesions can elevate the prolactin by disrupting the hypothalamic dopamine delivery. Typically modest elevations are seen, and stalk effect, the PRL is less than 200 nanograms per mils, but exceptions do occur, so use imaging to correlate. So the clinical clues can be larger cellular mass with only mild PRL elevation suggesting stalk effect rather than true prolactinoma. So management differs where non-functioning macroadenomas often need surgery if mass effect are present, and always interpret PRL level with the MRI size and clinical signs. So some of the pharmacological causes can be estrogen therapy, TRH, antipsychotic drugs, antiemetic drugs, tricyclic antidepressant, anticonvulsants, antihypertensives, H2 antihistamines, opioid analgesics, and cholinergic agents. And some of the systemic disorder could be chronic renal failure, polycystic ovarian disease, liver cirrhosis, pseudocyesis, reflex causes like chest field trauma, surgery, herpes zoster, and primary hypothyroidism. And genetic causes could be inactivation of prolactin receptor mutation, and bronchogenic carcinoma or hypernephroma could be the ectopic causes, and also it could be idiopathic. So some of the signs and symptoms caused by high prolactin In women, especially in premenopausal, it could be menstrual disturbances, oligomenorrhea, amenorrhea, menorrhagia, or infertility, galactorium. But most women who have hyperprolactinemia may not have galactoria, so less than 25%. And they also may present low bone mass. So in postmenopausal, it's usually visual side defects that you should look for. And men, they can present with decreased libido, impotence, infertility, oligospermia or gynecomastia, erectile dysfunction, galactoria, which is often rare, and low bone mass. And some of the signs and symptoms are headache and visual field defects. An extensive history and physical examination are important. Exclude causes of hyperprolactemia and detect signs and symptoms. So you should measure a serum prolactin level, ideally with a fasting mid-morning sample, not an early morning, but a mid-morning sample. An increase in prolactin secretion is associated with sleep, and if serum prolactin is elevated, the next step is to determine the cause in the following order. So exclude the physiological causes, look for pharmacological causes, and also neuroradiological imaging of the hypothalamic pituitary region is necessary. So these are some of the grades, like overt hyperprolactinemia is seen if it's more than 100, and suboptimal estradiol secretion is seen, and its consequences including amenorrhea, hot flushing, and vaginal dryness. Between 50 to 100 causes either amenorrhea or oligomenorrhea, and mild causes could be insufficient progesterone secretion and therefore a short luteal phase and menstrual cycle. And infertility, even in the absence of menstrual disorder, could be one of the reasons. So some of the laboratory tests you require are serum prolactin, TSH, renal function test, insulin growth factor 1, adrenocorticotropic hormone, luteinizing hormone, and FSH, testosterone, and pregnancy test. So imaging, you need to do a MRI of the pituitary with contrast if is preferable, and the visual field testing should be done in case of macroadenoma and tumor that is adjacent to or compressing the optic chiasma. So we should also be careful of the hook effect. An artifact in the immunoradiometric assay gives a falsely low concentration of prolactin. So hook effect should be kept in mind with large pituitary adenoma with mild or moderate elevation in prolactin. And when there's a very high serum prolactin concentrations, both the capture and tracer antibodies used in immunoradiometric assay become saturated, preventing the binding of the two to create a sandwich. Then the test result could be low, and this effect can be overcome by repeating the test in a 1:100 dilution of serum, and this artifact is uncommon. So when it comes to macroprolactin, which represents a large circulating aggregates of prolactin and antibodies of size of 150 kilodaltons, whereas the native prolactin is as small as 23. So these complexes are detectable in test assay but are biologically inactive and can be misdiagnosed as prolactin hypersecretion. And clinicians should avoid this misdiagnosis by precipitating macroprolactin by pre-treating with PEG, that is polyethylene glycol, before measuring prolactin. So let's come to a hypothetical case. This is a 28-year-old woman referred for infertility, and routine labs show prolactin of 120 nanograms per mils. She has irregular menses for the past 8 months, doesn't present with galactoria, or she's not on any psychiatric medications, and TSH is normal. You have done a physical examination, it's unremarkable. She has a BMI of 24 and a pregnancy test is negative. So what do we do next? So the options are whether we do a MRI, test empirically, or test for macroprolactin, or repeat the PRL. So repeating a fasting mid-morning sample of prolactin to confirm the earlier results. Ensure no recent chest stimulation or stress prior to the sampling. Review medications, but she's not on any antipsychotic drugs or psychiatric medications. The thyroid is normal. So we next do a PEG precipitation test to screen for macroprolactin given the moderate elevation in prolactin levels. So if PEG shows monomeric PRL elevation, obtain a pituitary MRI with SELA protocol. So avoid empirical dopamine agonist therapy until confirmatory testing unless symptomatic or large tumor is suspected. So if PEG is negative and the repeated test comes out to be 120 as previous, MRI likely required to evaluate the microadenoma. So a microadenoma may be found. Management will depend on symptoms and fertility goals. If MRI is negative and persistent PRL elevation, consider idiopathic hypoprolactinemia or microadenoma below imaging threshold. And for infertility, dopamine agonist therapy is appropriate to restore ovulation and improve fertility outcomes. Counsel about the timelines, menses and ovulation often restore within weeks to months if they put them on dopamine agonist therapy. So this is another case of 55-year-old man evaluated for erectile dysfunction, and routine labs show prolactin levels of 45 nanograms per mils. He has type 2 diabetes, stage 3 kidney disease, and is also on risperidone for schizophrenia for a long time. So you examine him, there's no galacturia, testosterone is borderline low, and visual fields are normal. So again, what do you do next? Is PRL elevation drug induced? Is it due to the chronic kidney disease, or is it wholly due to a pituitary cause? So there is high suspicion for drug-induced PRL elevation due to risperidone. So you coordinate with your psychiatric department to either change the medication, see how it goes, and evaluate renal function, because even CKD can reduce PRL clearance, causing mild elevations. And if medications cannot be changed, consider endocrinology discussion on treating hyperprolactinemia versus optimizing the psychiatric medication. So baseline pituitary MRI may be lower priority if PRL is modest, and clear pharmacological explanation is the background for this elevation. So address hypogonadism, check morning testosterone, and consider replacement after shared decision making. So the first line of therapy for prolactinomas is dopamine agonists like cabergoline, preferred for efficacy and tolerability. Bromocriptine remains an option. It has a shorter half-life and more side effects, and there's also a lot of useful in pregnancy data. So dopamine agonist normalizes PRL, restores gonadal function, and shrinks the tumor in most patients. So in most, like 95% of the patients, we see shrinkage of tumor. Choice of agent should consider patient comorbidities, pregnancy plans, and tolerability. So monitor for side effects like nausea, orthostatic symptoms, impulse control disorders. So the starting dose of cabergoline is 0.5 milligrams weekly, given at least twice a week, and titrate as needed. And most patients achieve PRL normalization and tumor shrinkage within weeks to months. So long-term low-dose therapy is common. Consider withdrawal after 2 years of normal PRL and no visible tumor. Counsel patients regarding nausea, orthostatic hypotension precautions, and start low, titrate slowly to improve the tolerance. Coordinate, it's also necessary to get echocardiography done, because there could be some valvular risk. So we have just time for another case, a 34-year-old woman who comes with galacturia, oligomenorrhea. You do a PRL, it's 250, and the repeat also the same. She is negative for pregnancy test. MRI pituitary shows 12 mm of cellular lesion without supracellular extension. Visual fields are intact. So what do you recommend is the next step? Start her on a cabergoline, or do you refer her to a surgery or further testing? And also we need to consider fertility wishes and symptom severity when deciding the therapy. So this is consistent with prolactinemia, because we have PRL of 250 and a 12 mm lesion. The first line, we need to start her on a cabergoline to normalize the PRL and shrink the tumor with close follow-up, and baseline pituitary axis and ocular fields documented. Counsel on the side effects, and also see how you can, if the pregnancy is planned, see how you can help her achieve her goals. And surgical referral reserved only if they are intolerant to dopamine agonists and there is mass effect. But medical therapy is highly effective in such cases. So some of the things you need to do is, there's a lot of inter-department communication you need to do with the radiology, the endocrine, the psychiatric departments. And
can you please wrap up?
Yeah. So these are some of the tips. So always check pregnancy and repeat the AM sampling if borderline. Review the medications if they're on any psychiatric medications. Ask lab for PEC test when symptoms are discordant with high PRL. Communicate suspected hook effect to the lab if large tumor is present. Prefer cabergoline for efficacy, tolerability, but counsel on valvular surveillance. Coordinate with the psychiatric department before altering the antipsychotic medication. Use MRI dynamic protocol for microadenoma detection, and document all discussions and patient-centered decisions. Consider referral to a pituitary center for complex cases and audit practice to reduce unnecessary imaging. Thank you for that.
Thank you, sir, for